All right, 7 o'clock, let's call the Midstate REMSCO to order and drop her sign. So drop the sign, first thing out the gate. Clerk, please.
I pledge allegiance to the flag of the United States of America, to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
So first and foremost, we had some bad weather not that long ago, just Saturday night. Had some fatalities, not to the EMS community that I'm aware of, but that the EMS community had to deal with. So if we could just have a moment of silence for the 3 in Clark Mills that lost their lives and everybody else who's had devastation from the recent storms. Thank you. All right. Ryan, attendance, please.
Right. Kathy Ebel,
Here.
Heather Bernard,
Here.
Nicholas Capron. Here. Kyle Cashel. Here. Cal Davis. Here. Bill King. Here. Eric English. Here. Vinnie Caroni.
I'm here.
Nat Held. Jenna Illingworth.
Here.
Ricky Rosari. Here. Dennis Johnson.
Here.
Drew Calmurray. Eric Merrill. Here. Jim Monahan.
Here.
Sean Murphy.
Here.
Leslie Myers. Rich Nauer.
Here.
Dave Paddock. Here. Bob Paddock.
Here virtually.
Ted Smith.
Here.
Josh Stagner.
Here.
Paul Taylor.
Here.
Joe Taylor. Eric Townsend.
Here.
Andy Vanderwalker. Bill Vinyl.
Here.
Ryan Ward. Here. Jerry Waffle.
Here.
And Jeremy Williams. Here. All right. Associates, we have Dick Bishop. Dan Burdell. Here. Robert Clark.
Here.
Donnie King. Dr. AJ Clinic. Anthony Police. Robert Schneider III. And all right, and guests, we have Melissa Lockwood. JJ down there.
Yep.
And Colleen. And we have Steve Olson. Right. Now we have a form.
All right, thank everybody for being here tonight. Let's, the minutes were posted, so let's, everybody should have had a chance to review those by now, and if anybody has any clarifications or anything for that. Okay,
I'll make a motion to second.
motion to accept and seconded, all in favor?
Aye.
Any opposed? Carried. Treasurer's report?
Account balances, savings account, $5,687.62. And then $5 for each, savings connected to each checking account. The fundraiser account, $4,250.98. The general account, $16,008.41. The opioid account, $9,438.64. And the state account, $3,164.42. Gives us a grand total of $38,570.07.
Anybody have any questions for Eric?
Take a moment.
Second. Okay, motion second, all in favor?
Aye.
Any opposed? Carried. Any bills? All right. Any presentations? Okay. We'll just run through standing committees then. Nothing coming out of executive committee tonight. Ambulance committee,
Ambulance committee, we have one action tonight. We met virtually. And I have all the information in front of me, so the Midstate REMSCO Ambulance Committee brings forth a seconded motion to approve requested clarification of territory for the City of Sherrill Fire Department. Ambulance Committee endorses the need for clarification and recommends the following terminology and wording that most accurately describes the applicant's existing territory without expansion. The new title going to be, quote, in Oneida County, the City of Sherrill, and the Town of Vernon Fire Protection District 2. And that comes forth as a seconded motion, has to be a report.
okay, so we have a seconded motion. Any comments? Okay, hearing none, we'll do a roll call vote.
Kathy Evil,
Yes.
Heather Bernard,
Yes.
Nick Capron,
Yes.
Kyle Cashel,
Yes.
Cal Davidson,
Yes.
Bill King,
Yes.
Eric English,
Yes.
Vinnie Ferone,
Yes.
Jenna Illingworth,
Yes.
Ricky Rosari,
Yes.
Dennis Johnson,
Yes.
Eric Merrill,
Yes.
Tim Monahan,
Yeah.
John Murphy,
Yes.
Rich Nauer,
Yes.
David Paddock,
Yes.
Chad Smith,
Yes.
Josh Wagner,
Yes.
Paul Taylor,
Yes.
Eric Townsend,
Yes.
Bill Vinyl,
Being mayor, I will abstain.
Ryan Ward, yes. Jared Waffle,
Yes.
and Jeremy Williams.
Yes.
There's only one extension, the motion passes.
Have the number.
We need Lucenberg.
23 yes, one abstention.
Yes.
Thank you.
Gotta do the math in my head.
Okay, I was kind of.
Man, that's all the ambulance committee has.
Okay. Any other questions for Paul and the ambulance committee? All right. Bob, anything on the education committee?
The education committee put together the training piece for the protocol rollout that's effective July 1st, 2023. Hopefully the wave of the future for the education committee, where we'll have a number of education items that will be available to the providers in the region. And this is a start, and we hope to be maybe a little more in depth in the future, but with timing constraints and personnel, we put it together in a timely fashion for July 1st. So that's really all I have. Our next meeting would be in the before the July REMSCO.
We have any questions for Bob? Anything from bylaws committee?
Just what was mentioned in our executive session, which is we will be putting together a new committee specifically for CISM. There are some guidelines that it's going to have to meet. Therefore, we will set this up and actually officially do it so that it will be a committee that follows our bylaws. Personally, any questions you can ask us.
City legislative?
Yeah, so just as a couple of things that I want to bring to your attention. So a bunch of bills related to EMS passed legislation and waiting for the governor to sign them. One bill passed both houses. It will remove the 2% tax cap for counties and municipalities and villages and towns to raise funds strictly for EMS. So they can go over the 2% tax cap if it's for EMS. Now, the governor has to sign that, and there's some question about whether she's gonna sign it. There's some concern that this is a slippery slope. If she if we do it for EMS, then there's a concern that everybody's gonna have their hand out to raise the 2% tax cap. So the legislation passed it, both houses. So, it's in her hands now, so we don't know. We're watching to see how that plays out. Another bill that passed both houses is a EMS throughway bill. And it eliminates tolls for EMS agencies. Responding to calls, and I didn't see the bill, so I don't know the particulars of whether it's just emergency calls or non-emergency calls. But of course, the Thruway Authority is opposing it, because they think, again, it's gonna start a precedence of everybody using the Thruway for free, so. So the governor has the ability to not sign that one also, so we don't know where that's gonna go. Another bill that passed is an electric vehicle bill. State Fire has to develop training specifically related for EMS involvement in electric vehicle incidents. I can't imagine that one will get signed. Cardiac plan passed. Schools have to come up with a cardiac plan to respond to cardiac instances, be it a cardiac event or cardiac arrest. The schools have to come up with a plan. I'm assuming that they'll involve EMS of what that plan is gonna be. The buprenorphine, how do you say it? Buprenorphine, that got stalled in the House. Passed the Senate, got stalled in the House. I don't know why. There was some changes done at the 11th hour, so that's stalled in the House. That's where we can administer buprenorphine to withdrawal patients, so that's stalled in the House, so we know it's gonna go. The big thing is, I mean, that passed, and this will get signed, or, small money says it will get signed, is it's a county plan. So the county in concert, municipalities, including the county, it depends on how the county wants to roll it out, but the county is responsible to work with the REMSCO, develop a plan, comprehensive EMS plan. So, I had a meeting today, the state legislative committee, the SEMSCO legislative committee today, and there's a lot of concern. This bill, we have 6 months from when the governor signs it, to come up with a comprehensive plan. A lot of the REMSCOs aren't gonna meet over the summer, so that's gonna take away some time. It's gonna be pretty difficult to get these, county execs and legislative people in the same room so we can come up with, work on a plan. And what they're trying to do is they want to assess the status. This is really, this is like a first step to, the essential service bill. So this part would talk about, where the needs are, what the wants are, what it's gonna cost to accomplish what our needs and wants are. So I don't know how we're gonna do this yet. But I think it's gonna be a pretty big lift for some of the counties. Now, Jenna and I were talking earlier, and Madison County's got a pretty good handle on it because they have the countywide CON. Oneida County is a different animal, right? So we're gonna have a lot of things to look at. Things like scratch numbers, where are pockets of what they call those ambulance deserts, in where those pockets are, and how we're gonna mitigate that. So over the next few months, be working on that. One of the biggest concerns is, along with this bill, there was no funding. So when we talked to the state, we had the state on the phone on the Zoom meeting today, and there's no funding, and their hands are filled with a lot of stuff, so the people I help with the legislative stuff. So I don't think we're gonna get a lot of help there, so. I don't know how it's gonna move forward. We'll find out, so stay tuned. The other thing that's going on, is, at the state level, the vehicle regs, the vehicle and equipment regs, that's going back out again for 45-day, comment period. So if you're interested in making comments on the new standards or the proposed standards, the regs will come out for a 45-day comment period. But the blood regs are in draft form. They're working with Wadsworth, the state. So this is the part of the state that the people who do the regs, right? The legal eagles that do the regs. So they're working on these regulations. So the blood regulations are in the process of draft form. But now there's some concern that there might be some federal regs that they'll have to work with also. So that's moving forward. The community paramedicine bill is moving forward. There are people working on that. And then the other two things that are going on, are the performance standards at the state level and the quality metrics that the state's working on, the REMSCO, SEMSCO is working on to, further the performance standards and quality metrics. That's really all I have for now. Anybody have any questions? I'll try to answer.
It's pretty interesting with the counties and the REMSCOs. And it's gonna be 6 months after she signs the bill,
Yeah, we have only 6 months.
and you
They
expect
they
her to
want,
sign it?
yeah, Smart Money says that she will sign it because it was in her initial, budget. So this is something that she wants. So she wants a comprehensive plan. How we're gonna fix it, and
Given the diversity of our region, the counties,
it's gonna be.
it's gonna be a tough thing. And Chad, you might want to, start the ball rolling when meeting with the coordinators and maybe you and someone else to set up even a sketch of how you would propose that this might happen for our region. Just a thought, get ahead of the,
But we're gonna have to, yeah, there's gonna be several meetings. Now, we used to meet pretty regularly to kind of Oneida County. We haven't done that in a while, so we'll probably have to.
Last week,
Was it?
not last week,
No, I'm talking about on the 10th, up on the 10th floor.
Yeah.
So that we'll have to get that, because the county's responsible for this, right? The charge, the bill says they have to work with the REMSCO to come up with this plan, so. So we'll have to reconstitute that meeting. So. Oh, that's all I'm looking.
I have no other questions.
Any other questions or comments? Thoughts?
Any word on making it essential service, EMS is essential service, because I was hearing that bill.
Well, no, that bill got shot down, but this is part of that. The argument is this preempts the essential service. They need this information first. Right, once we have this information, then we can make an essential service. And again, the bottom line is it all comes down to money. Right. Who's gonna fund all this? That's, that's what's money's gonna fix a lot of the problem, but where's the money coming from? That's the question, so.
Dovetailing on what he said about the vehicle regs and equipment regs, when those come back out for public comment, it's very important that whether they're negative comments or positive comments, they especially want positive comments, but they'll take negative comments. They just need comments, is this is ours, this is EMS, this is what, we say. So this is your opportunity to comment on them and say, I like this, I don't like that. And if we get enough of a voice behind something we don't like, it's, their opportunity to bring it back and revisit. So make sure that you guys go out and talk to your agencies, talk to your leadership, talk to your providers, have them look at it too, because it affects them as much as it affects the leaders of the companies.
And what do we put up, how they can do that? Where do they find it?
How
How do they look at it?
is there something that gets posted that
It's
only gonna be
affordable last time. Yeah, but it's also gonna go out it's going out for public comment, so I don't know where, but. I'll
Once it
find
goes
out.
out for public comment, I can get the link.
It's on boardable.
Yeah, I know it was on
Not everybody has.
we can put, maybe we can put a link out through I Am Responding or something.
Go on responding, go on our website.
State of New York uses portable for communication purposes, so they give access to all of REMSCOs for that purpose.
Right, but what about?
Yeah, but what about the
rank and file? What
public?
about the?
And they give
That
it
we
to you,
work.
and then you put it on your website.
You could put it on Midstate's website. No.
So once we get that, we can put it out in a very wide range of media,
Social media website.
mediums, anyway. All right, PR,
So we met tonight. We've been meeting pretty regularly with the golf outing that's coming up on August 17th. We do have, some sponsorships. We're still trying to get more, sponsorships for the golf outing. We're getting some donations as well. We still have 14 open team slots. So, Sharon and I have literally talked about going door to door to every EMS agency to make sure that they have copies of the flyers and see if anyone else is interested, because having 14 open teams is pretty full, but So if you know anybody likes to golf, let me know and I'll send out I can send out the flyers to anybody, or if you know anybody that likes to donate or sponsor things, let us know, so we can reach out to them as well. Or we are,
How many teams are there?
32, 36
36, and that's,
total, we have 14 over.
oh, only 14 open, so it's still a pretty good number.
Any other questions for PR? Eric, finance,
No report.
safety,
So I've been working with safety to set up a new team. I've got 5 other people interested. We just didn't get to a meeting this month because I ran out of time. So that was that. As far as SISM, I've been talking with Rick. We're gonna set something up before our next meeting and work on that stuff. We've been busy as far as the team goes. Just responding to different calls. The Hero program officially started. We had our first meeting and inauguration this month on the 10th. The 11th, sorry. And it's gonna be a very busy thing. Gonna use my agency. The portion of this to do it is they want to set up more of like a peer-to-peer to help everyone do mental health and wellness. So I'm gonna use my agency as my guinea pig to get all this whole program started and then transition that into the region, so we can have a region-wide peer-to-peer with our SISM team. So it's gonna be a very long year getting everything set up, but our future looks bright as far as well-being.
how does that program mesh with the SISM that we currently,
So-
that we currently have? Is there a lot of overlap, a lot of things that are very similar, or is it really drastically
So
different?
it's made up of 20 different providers throughout regions. Some are EMTs, medics, social workers, SISM people. And the biggest thing is now trying to get mapped on where all these different teams are. The state had not a clue that we have a region-wide SISM team. They didn't actually know we existed. So now they do. So that's cool. But as far as the overlap, it's not more for SISM, it's more for peer-to-peer. That's what this is really geared towards, is, you know, getting you to go out and talk with your peers and get things like that. So it's not really geared towards the SISM, it's geared more towards peer-to-peer support.
Anybody have any questions for Josh on safety, SISM, the Hero program? Okay, membership?
I got nothing.
Dr. Black, anything from Elaine's bill? Okay. Anything from REMAC?
Yeah, so we met last week, and discussed the new protocol going out. They were all pretty much approved except for olanzapine in this region and the antibiotics. We came up with we had initially talked about doing a application for supraglottic airways. We then turned it into a BLS adjunct application and notice of intent. So that sheet is going up on the website. Basically what that is, if you were already existing in the CPAP program, epi, naloxone, anything like that, you won't have to fill out this application. But for going forward, we'll use eCert4Fire, for example. They're getting back into the EMS game, so they'll be using that. And they can check off everything that they want to do BLS wise. For the airway section, CPAP, definitely CPAP and SGAs, there's different stuff that they have to do. The nice thing about this is it gives Dr. Black provisional abilities to approve them for the time being until we have a REMAC meeting and the REMAC can discuss further.
How about the agencies that have participated in the?
So agencies that have participated in the pilot, my understanding, already go into this as approved going forward, starting July 1st. They do not.
Sir, just out of curiosity, if an agency is gonna use a supraglottic airway, BLS agency.
Yep.
You fill out the form, Is there standardized or is there anything for the training?
Yes, we have training from the state and Hudson Valley that we are going to use. For that
And that'll be available on,
collaboration,
okay,
uh,
good.
or. You know, I myself, as long as it's not a class, I would be willing to come out and teach the class.
Good.
One thing, BLS agencies, you do have to have continuous waveform capnography. Which typically BLS agencies don't have a monitor. They do have devices, portable capnography devices that were approved by the CMAC and REMSCO. For agencies, we didn't specifically put the brain down. All brain down because we didn't wanna.
Is that the same device that we used to use when we first started that capnography?
The little purple.
Yeah,
ones.
a little perfect.
So these are digital. But they don't transmit and they don't print.
They're allowable,
They are allowed.
do you know what do they run, do you know?
So the one that my agency is looking at is about 1,500.
Holy cow.
And our policy,
Doesn't, right.
we haven't written the policy, but we're looking at taking a snapshot of the device and attaching it to the chart. Just so that we can actually show correct documentation. Other than that, REMAC was short. Week last week,
Next REMAC meeting is,
September. After, state meetings.
September, third Tuesday,
Third Tuesday.
16th. For those of you playing home version. For 2016. All right, few more things and we'll get to some old business and talk to some people that can. Program agency report.
Sure. We'll start with enforcements. Stephen Tanner, community number 430-642. Violations of 800.16, 813, surrender discard effective 6/20. Montega Shaker, EMT number 519-343. Violations of part 800.16 suspended for 3 years. The suspension is stayed pending no further violations. Assessable penalty of $2,000. Evan Torres, EMT number 498-621, violations of 800.16. Suspended for 3 years. Suspension is stayed pending no further violations. Assessable penalty of $2,000. We've had 2 QAs since the last meeting, both of which were handled at the agency level. One was agency level and region level, with nothing going to the state for any further investigation. The REMSCO contract was finally approved after Chad and I rewrote the roles and responsibilities for Dr. Black. Dr. Black looked at it, signed it, Chad signed it, we sent it to the state, and contract has been approved. We are still waiting on the program agency contract. Quarter 4 was submitted and was rejected. There's a couple numbers that we have to fix with Cheryl Jackson from the hospital, and that'll be submitted coming up shortly. The new minimum equipment list was updated and put on the website today. Protocol update, I want to thank Ryan and Bob for all their hard work on that. Ryan did the presentation and Bob did the voiceover. So that was a good job on that. And the only other thing I really want to bring up is with the weather that went on over the weekend and, you know, the wait times the last couple days at the hospital. You guys are doing a fantastic job.
The minimum equipment list. Tammany. 2 in the ambulance, 2 portable, things required.
No, yeah, we didn't change anything from the last update. Any of the medications other than Haldol was taken out. And then anything that was. Yeah, so everything is the same from the 2023-2024 update, except for the pro. So I mean, we can discuss it after if you want that. Absolutely.
Do you have a little comment, Perry, that you remember?
What's that?
There's a local comment period for your ALS list.
Never knew that was a thing, because we didn't the last two updates either. That I'm aware of.
You did, I was just asking.
Should we?
Okay.
She brought it up. Brought it up.
I couldn't hear the question.
I'm just asking if there's a local, like if an agency wants to question, do I have to carry this much? Paul's done it in the past. As an example. And, no, he doesn't have a problem saying that. So there should be a means, in my opinion, and this is my opinion, not as a state employee, but as a local EMS provider. When I have a means to comment on for discussion at the REMAC. Yes, no, they don't have to agree with it, they would give you the option to have your opinion put out there for a discussion period.
Take that back to Dr. Black.
Just an idea.
Yeah, I'm okay with that.
Some things get expensive, some things get unused and unused and unused, you carry it and carry it and carry it, so maybe it should be something to discuss.
We're
Yeah,
definitely
that's-
open for any discussion that's requested.
Yeah, no, that's, just so you can discuss it, because currently that is your purview as the REMAC, they have the ALS list for yours, so. That way agencies can say, we never touch this ever, why do we have to carry it, or can we carry less of it, so we're not wasting so much of it, type thing, so. If there's a way to do it. So they can
Yep,
put it out.
I'm willing for any feedback that wants to be given to me. I'm willing to interpret.
Beautiful. How's that work, JJ? And for the record, that's Melissa Lockwood, local paramedic.
With,
Wait, your section's next.
Independent, we'll get into that when my report comes up.
all right. Any questions for clinical coordinator program agency? Anything for state?
So yes, last June. The EMS education regulations were updated, and in there was a addition of an independent person that can renew via CME. So you didn't have to be with an agency, you could independently be unaffiliated and do your CMEs, which never been able to do before. You always had to be affiliated with an agency prior to that. It took a couple months for the IT services and everything to get the button in place on the portal. So there is a portal for that, and then it took until last week.
And a button.
Yes, a button on the portal. And then it took until last week to finally get all of the approvals for the actual policy to give you guidance as to how to do that. Absolutely everything is exactly the same. You need all of the same signatures and such, which makes it a little bit more difficult. If you are someone who's never been with an agency, put yourself through a, let's say, basic class, and have never been affiliated with anybody, so you don't have connections, you will still need a CIC signature where it says CIC or training officer signature. You'll still need a medical director signature, which is defined, I believe, in the policy as a local regional approved medical director. And if you aren't someone who is known, they don't have to sign yours. So I get a lot of calls from a different part of the state that says, nobody will sign my paperwork, make them. I can't make them. So it is more difficult to be independent if you're not known. And it might be independent even if you are known. No comment necessary. So you
What
can do
is
that.
a local approved medical director, man?
So you should have a list of approved people that can give medical direction in this region at the hospitals and such.
So you're talking about medical control lists, like the regional
Sure.
medical control list?
Yeah, yep, any of those, and anyone that have agencies under them as well. So like Dr. Clemic over here has a couple of agencies, he can sign off on CME paperwork. He is approved by the region, he has agencies in this region, he can sign off. You have several agencies in this region under you, you can sign off on them, so any of those type. If I have Dr. Joe Smith, who happens to be a podiatrist that has no agency affiliations here, he probably cannot. So
Not necessarily medical control positions, but medical
Correct.
directors
Yes.
of
Yeah,
agencies, okay.
so I may call.
Verify that.
I may call this office at some point in time and say, hey, I've never heard of this position, and it's somebody new to the area, and when I call, I will call Ryan, or I currently will call Jared, and they'll say, yes, that's a new position, and if they don't know, they may call Dr. Black, because it may be somebody from that direction, or whatever, I may have to track down and see. It'll take a little bit to get used to, but they still need the same exact signatures. The only signature they don't have is the one on the front of the first page where it says agency contact. That is the only signature that is not required. All the same hours, all the same signatures, everything is still required. They just don't have an agency, so there's no agency number and there's no agency contact. You can also use that if you're that person who doesn't trust your CME coordinator and want to put it in yourself, in which case you may still have an agency coordinator and an agency number up there. So, and there are those people up there. I was one, which is why I became the CME coordinator, just because I didn't trust people. I've been at agencies. I was staff leased to an agency. I watched somebody, oops, I forgot, and watched 3 people lose their certification. They have to take a refresher. Years ago. Do you remember that, Chad?
No,
Okay.
I don't.
It was a very long time ago, and we were friends, and he was familiar with the case I'm talking about. So it does happen, so you can use it for that as well. So it's allows anybody, affiliated or not affiliated, to utilize the ability to put their own CMEs in. And now we have a policy that has been posted as of last week, 2506, that gives you directions on it. It is a new policy. Therefore, I get 150 bazillion questions every day about it, but hopefully we'll get it streamlined a little bit. So if you have questions, feel free to ask. Enough people have my number. So that is out there and about. On the operational side of things, a couple weeks ago, Vinny and I picked the worst night ever to go do spot inspections. And it was a very busy night. It did finally slow down just a touch, but it was a very busy night. So I did see a lot of not so happy, smiling people. But it was really a very productive night. We got a lot done. Everybody was in really good shape for the most part. Everybody was surprised to find, yes, just about everything on an ambulance does have an expiration date. And yes, we're not joking when we say it's coming to date on the suction canister. Suction canisters very often do have expiration dates, and they are on the side, but for the most part, not a problem that night at all. And we were also lucky enough to go to the Boxing Hall of Fame, Part 18 inspection. That went wonderfully as well. So it's really nice to be in our own hometowns and see a lot of really awesome, in shape, clean, nice, well stocked, and by smelling friendly faces that we either taught or have worked alongside people on rigs. So it was a really nice experience. So good job for everybody. And over the weekend as well, with the weather, can't be said enough. A lot of people were out and about. It's been very hot. It's been very busy, and I've taken some complaints about wait times and such over the last couple of days, but everybody's been very polite and working as well as they can in the situation. I've been doing it because Vinny's been out, because he's in Clark Mills where this all hit. So he's been a little bit busy, but thank you for your patience and politeness during this very trying times. So, anybody have any questions for me?
Melissa was at CME.
I just knew it. Like, wait for me to stop.
We're at CME.
Question, did anyone meet Sydney Sweeney?
Who's Sydney Sweeney?
She was the grand marshal of the parade. No one's familiar with her work. Google Sydney Sweeney afterwards.
I was nowhere near that because where they parked the EMS is off the parade route. So we did not get over to the parade route, unfortunately. So I did not. Now I have to go look up.
Apologies for putting my command post out of.
No, you did appropriate.
No,
So
but-
we never get to see the good
But
stuff.
what Ryan actually did not know is that if something happened and they needed to evacuate her quickly and immediately, the ambulance that Ryan was on was actually the vehicle that was going to be doing that. They were going to throw her in that ambulance and tell you to drive west on the freeway as fast as possible.
First one we got to the end, that would have been nice to know.
Yeah,
Yeah.
yeah. That's why the police chief making you park in a different spot than he was supposed to really kind of could have affected things.
So with an independent CME program, is there a cost associated with that?
No, So there may be a cost for the independent person to get their CMEs because they're not affiliated with an agency, so if they take
Yeah,
some means to
CIC
get
or-
there, no, so locally, for sponsorship could, essentially apply a price to say, once a month, we're gonna do skills for every level, and we're going to charge you $20 to come in and do that, that's up to a court sponsorship, that's not mine.
Or for content hours, I'm assuming as
Or
well.
for 10 hours, because if I am not affiliated, we've always done that here locally. You, not we, I used to, I don't any longer, sorry. But that's always been a thing that because we have done the core content remotely, you had a price affiliated or fixed to that here. So that could cost you, so it's not easy to be independent, but it's not impossible anymore. Same goes for skills, they'll need skills signed off, Brian, so just so you're aware, don't be surprised if somebody comes knocking on your door and saying, I need somebody to sign off my skills at some level or another.
Oh, we've had a few so far. that
Okay,
have come through.
I send them to you, I send them, I look up to see where they're from and I send them.
It's usually the first thing out of their mouth, they're like, Melissa told me to call you.
Yeah, I look them up.
Like, I know exactly what you're calling for.
Yeah, so, yes, they do need skills, so if they do randomly come to your agency as well, that may be, you know, what they're looking for, and if you have a CIC who's able to do it at their level. That is up to you whether or not you do that or not.
So there has to be a CIC now to sign off skills?
It
'Cause
depends
in
on the
the
level.
current one, there doesn't. It has to be training officer, or medical director signs off
Correct, if you
skills.
don't have a training office, and you're gonna have to have a CIC.
Sorry.
Or something. You'd have to have something that, I mean, I can't have my best friend over here say, sure, and Kelly Smith isn't even an EMT. So,
I'm just wondering, I mean, if that.
the appropriate person has to find the appropriate place.
Are we still talking to core content research? Yes. You have to have a CSU to teach them pure.
For the core content, yeah, we're talking about
If you're
skills.
doing in-person teaching, yes.
I was,
But you could also be doing online. A lot of people have Vector Solutions, EMS One Academy or whatever, which you can buy. Joe Schmo can buy, go buy it myself if I want to pay out the tickets for that. I can buy access to it myself. I don't have to do it for me. But I still have to have a CIC sign off on that, even though I bought it through a company that's been vetted. I still have to have your signature on it.
Any other questions for state? Okay, old business, I still have regional county MCI plan on here. Anything? Any updates on that?
we're working on updating run accountants.
Okay. It's on here, so I'll mention it. Rick's nuisance calls. I want to reopen the can of worms, but any progress on that yet?
The case word never been closed.
But no progress that we're aware
I have no progress.
Okay.
She says hi, Rick. Again today.
Besides the fact that I've been asked by other agencies to take care of some of these things.
Okay. So the EMS forum at the Wynn, from what I understand, the next one is an evening one.
It is. It's scheduled for September 19th, which is the same day as our fall forum. So we're gonna try and get it moved either a week before or a week after.
And the last thing I had before, we get to the last thing I have, so the next last thing I have is cops and deliverables. I don't know why that was on here, if that was, I don't remember if that was for everybody to, for the REMSCO members to have, or for.
Let me do that randomly.
Okay. This is why I write these things down now. Okay, so the last thing I have under old business is, yeah, totally did.
Okay.
You know,
I was kind of out of place too.
yeah, no, I totally skipped right over that. So pretty short in the meeting a little bit.
I appreciate it.
Apologies. Guess we'll come back to old business again. County reports, anything from Kirkland?
We had a EMS advisory meeting last week. Went okay, and nothing else for her.
Oneida?
A couple things, we're working on our new CAD system, which is gonna be upgraded on July 15th. As well as the RMS. We did have a meeting last week to try to discuss. Better dispatching ambulances, whether they're available or not. Unresolved at this time, we're still working on that, probably have another meeting. In the next few weeks, most likely at the Boilermaker. At some point to discuss that. We do have Boilermaker coming up July 13th, a lot of agencies are involved, so we appreciate that. We're still looking for a few UTVs. If anyone knows any departments that has a UTV available for us, be able to utilize for the Boilermaker. We are working with the WIN to do an MCI drill at some point this fall, so that is gonna be trying to get a number of agencies involved with that, so those meetings are supposed to start in the very near future. Hopefully we'll have something towards the end of September, beginning of October for some type of MCI drill for the WIN. That's it.
Are we having our meeting in the third, like we scheduled last week?
We are. Okay.
That's back.
1300, was it 1 o'clock or was it?
1 o'clock.
It was a.
Excuse me?
1 o'clock.
It's the day before the 4th of July.
I'll send it out to you, right?
And then they're excited for the rest of those.
I think it's 10 o'clock.
Meeting in Item 1 Center, 10 o'clock for CAD integration, yeah.
All right. Madison County.
So Madison County's MCI plan was updated last year, and we put it to work this month. We did an after action and found out that EMS does the MCI plan really well, fire and police, not so much. So we are going to be planning some MCI drills over the next few months. We're gonna do tabletops first and go from there. We also activated our disaster plans over the weekend because we also got hit pretty hard with those storms. We almost had to help poor Bill evacuate out of his building. But again, we pulled together all of our EMS agencies and we had backup ready for him in case he needed to go out of service and we could cover the city of Oneida with all the rest of our ambulances in the county. So everybody came together real well. We've learned that these meetings that we hold every other month actually pan out well and their communication has highly improved over the county. And we are looking into some new methods of holding A-level calls. So we've talked about it at our meetings and we're going to doing a trial run with some agencies that have a larger majority of A-level calls versus some agencies that don't. So we're gonna trial that for a little while, see how it works and then put it into county policy. So we are working on that and we have a meeting tomorrow with our EMS agencies and the county board of supervisors.
Anybody have any questions for any of the 3 counties?
I would just like to add that all 3 counties that are looking at holding A-level calls should also consider integration with what we were discussing before, which is getting rid of the nuisance calls, and that'll help a heck of a lot bringing up our agencies. Won't let it die.
Don't let it go. Simple business. You're all really old. No, it's not. All right, nothing for state council reports, which now brings us back to old business. And so at the last meeting, it was requested that we send out a letter to the hospitals to have representatives come and answer, you know, not, I don't want to put them on the spot and say, you know, make them accountable for anything, but like, a lot of us in the council had questions on, I believe it was specifically hold times and what the other hospitals, what all the hospitals' plans were for that. So I know we have Steve here from the Wing Hospital. I know Heather is from Hamilton Hospital. I don't know if she's prepared to speak on that or
We don't have a problem with holding lines, we have more problems getting patients out. No lines in the waiting, my space.
So. I guess the floor is open. If you guys have questions if there's another hospital representative, Dr. Kirby can probably speak on behalf of Oneida. So, if anybody has any questions. We have 3 of the representatives here. Now's your chance.
Dr. Black, is there an issue with holds in Oneida? As far as turning over patient care when an ambulance gets there?
So I mean, that depends on the day. I can say that today we did not have any prolonged offload times. I mean, there are times in the past that we have over 35 people seeking care for 13 spaces. And sometimes it takes a lot of doing to get an ambulance offloaded. But we do try to aggressively attack that with creative hallway locations. And then boarding, as far as inpatients is concerned, can exacerbate those issues. And that also comes and goes. So it's entirely variable based on the week or the month. Currently, we're in a good spot, knock on wood.
Yeah, I don't use many problems with it at all.
Yesterday was kind of an exception to the rule with the patient load over at Winton Hospital. And what we saw yesterday was something that we've never really seen before, where they actually physically took hospital beds and they placed them in the EMS hallway, the Columbia Street corridor there. To me, that made all the difference in the world. And I don't know if that's gonna become a norm or if that's just a case.
Yeah, that's the intent. That is the intent.
Cause that made all the difference in the world. I mean,
Agreed. Yeah, there's been a lot going on. I'm only there 8 weeks.
Yeah.
But in that short time, we've made some plans, so this July 8th, we have a whole new method. So when there's empty rooms, what the expectation will be is that EMS will take the patients directly to the charge nurse or someone designated. And they'll be triaged in the rooms because that's the national standard. That's, you're full till you're full. And then obviously once that is no longer a thing, we'll revert back to, there'll be staff on the back hallway. Yesterday was, it was interesting. We had 233 patients we saw yesterday. We had 3 left without being seen. And at one point we had, I think, 110 patients active in the department. And so if you think about that in terms of capacity of the hospital, we had about a third of the capacity as active patients in the department. So, I think the EMS guys did a great job yesterday because there were some that they just brought them right back. There was no waiting. And it was obvious, there was guys seizing and things. So, it takes the team. But yeah, the intent is to offload them back there or not try to stop there. I'm not gonna ever tell you guys there's never gonna be a wait, because it's just the nature of, just like you saying at Oneida Hospital, right? I'm in communication all the time with the folks who run Upstate and Kraus and St. Joe's. So Upstate does a similar, unbeknownst to me, I know the person who does my job at Upstate very well. And so I just texted her out of the blue and just said, hey, what's going on? How do you, and she said, oh, we do this. I said, oh, that's interesting. Good idea. The other thing is there's lots going on in terms of the space. So we've been making a conscious effort. I have, including buying the stuff myself to get stuff in that room for you guys, because it's hard to be out on the road for, 3 hours and then there's no water, there's nothing. So it's unacceptable. They took away, they replaced rooms. I don't know what happened before I got here, but I'm advocating for that. I'm an EMS person historically, a very, very long time ago. So I know, you know, it's a hard job. Sorry. So, yeah, I understand the challenge that this waiting poses. So that, you know, like with yesterday, of the 64-ish, 65-ish beds we had, 48 were full with admitted patients. So ED throughput issues are not an ED problem. They're an external, or they're external forces that we have no control over, unfortunately.
Well, I realize that the ER doesn't have any control over that. That's totally understood. But what is the problem with the throughput?
So
Is
what
it the hospitalists not discharging in a timely fashion?
there's a few things, and actually, we're starting up a new thing that I'm actually glad to see. And so what it is it's basically a bed meeting. So I don't think that there's a push yet, and I say yet because they will be being pushed a little. First of all, we don't really push hard to get patients out by 10.
We were told 6 to 10 months ago that was a
Yeah.
priority.
I'm sure
And we recognized that
I'm sure
it was
you
a
were.
problem, but
Yeah, this is,
it's not you.
no, I don't take any of it personal, I don't, I'm
No.
telling you that I know that. But it is unfortunately not an uncommon problem nationally. So, you know, if we can figure out how to fix it there, then we should just sell it. And it's, don't understand, or please don't misunderstand, I don't think it's acceptable, and I don't take it lightly. But I just know that there's a certain impact, and I'm sure that the push was for 10. There has been a change in the way case management structure reports, which I think will be helpful. They don't report. They just have a different reporting structure, which I think is gonna be beneficial. Because there's a lot fewer on our 8 a.m. meetings, there's a lot fewer patients that are pending discharge. So, you know,
Positive.
yeah, we do have actually a very high admission rate versus obs rate related to the national benchmark for that. So I think there may be some help and education for the physicians. Dr. Zimmer is he's very progressive about stuff, and he's not afraid to have conversations. So, you know, like I said, I've only been there 2 months.
I was one of the more vocal people on the council that thought that it was really important that we had hospital representation here. For us to better understand
Yeah,
what the throughput problem was and causing the problem, but just as importantly, that somebody from the hospital, other than Dr. Black, who is on the REMAC, understands, not just theoretically, but understands the impact specifically the single hospital in Utica has on 3 counties.
oh, yeah,
I mean, let's say that the wing is got people stacked and they're backed up. That immediately, if they're either not able to handle something or they've got rigs backed up that they can't get in the door, which frequently happens, that overflows to Rome and Oneida. Oneida only having 13 beds. If they got in an influx of 2 more ambulances they don't normally see, he's underwater. If Rome gets 3 or 4 that they don't normally see, they're underwater. And that is a direct result of the inability to offload at the Wynn Hospital. I understand, and it's not that the ER people aren't trying, but there has to be a mutual understanding that this one thing that happens in the city of Utica affects 3 entire counties, if not more, because Utica can't get, if Utica Fire can't get their ambulances out the door, and Kunkel can't handle the calls, and Edwards can't handle the calls, and COC can't mutuate into the city because we're 4 ambulances deep, or 5 ambulances deep,
11.
to handle a call 5 ambulance services deep, not numbers, 5 ambulance services deep to handle a chest pain on, give me a street, Rucker Street, something, right? In downtown Utica.
Kennedy Plaza, a block away.
Why is that? Because we've got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11 paramedic units that can't offload their patients or told they can't offload their patients. And the guy with chest pain is now gonna get an ambulance, gotta believe it or not, Kaikoura, which is 30 minutes. And it's just the regional impact is horrible because Utica's getting killed. Utica Fire can't keep up with it. Kunkel can't keep up with it. Edwards, Christ, I bet you half the calls during the day are mutual aid to Utica to help.
At least.
And COC is sending rigs every single day. There's just, there's no more to handle. There's no more places to pull ambulances from. So how do we look at solving? The numbers of patients aren't going down. We would love to get rid of the regulars. We would love to. We would love to have. We would love to have community paramedicine and being able to sign people off in the field and say, you know, you don't need to go. That is an option also, but that's in the future. How do we solve people that can't get anything for chest pain? That's
So-
my question.
So one of the ways that I try to solve problems, including problems that the hospital do, is involve the stakeholders in the process solutions.
Mhm.
So I don't know if you all are on listservs with other communities or in other areas or have communication with other EMS agencies that have ideas. I'm open to any ideas that because I think that this is a shared responsibility of the community. Not necessarily a Wynn Hospital problem, in other words. You guys figure it out, you're a bunch of idiots and we'll just stand here and complain. That's not what I am saying. What I'm saying is, that's the opposite of what's gonna be helpful for the community.
Right.
What's gonna be
And
helpful.
again, that's the reason why I wanted this.
Yeah, so what's gonna be helpful is, just help me. But tell me what, and because I've offered some, I will tell you this, I've offered a few solutions on occasion. And I met with certain comments that, oh, that won't work because EMS can't do this. And so, okay, that's fine, I don't know that though, right? So what we need to do is have a discussion or a different plan. So if we have to hire paramedics to stand in the back hallway, well then, we'll hire paramedics and they'll stand in the back hallway and they'll all offload your ambulances and then they'll be responsible for the, I mean, those are all things that I'm thinking of.
Yeah, those are all possible solutions, but I don't think, to your point, I don't think any of that will be solved unless possibly the throughput problem is solved.
Right, well, I don't have
Because
control
you can't
necessarily over the.
work above you.
Right,
You can't solve your problem.
yeah, there are some new things, like I said, bed management meetings, which are gonna be helpful. That have not been being done, which I find very odd. And I've worked in big places, this is the first place I've ever worked. Where they would have huddles, but they never discussed the throughput, they would meet for staffing, but they wouldn't talk about. What patients are leaving tomorrow, today.
We can bring our ideas back to the table with you, but I think the frustration here, Steve, is we have given these ideas time and time.
I know, and I'm sorry about that.
18 months.
And
There's nothing I can do about it,
You're fresh.
and I'm not going anywhere unless they fire me.
One of
I
the,
understand.
one of the unintended.
I'm a fighter.
One of the unintended consequences of us being trapped in the ERs is now our interfacilities that are coming out of your facilities.
Oh, I know.
3 to 4 hours late, and what we're up against is when we're arriving at the destination, and now they're refusing our patients.
Yeah,
So something
it's a mess.
something to consider is the possibility of if we're ending up bringing these patients back, why should they have to sit in the ER versus going back up to the floor? Because
Yeah, those are maybe one-offs that we'd have to figure out, and I've also asked sometimes, why certain patients that are in that back hallway. So I've been a nurse for about 25 years. I've been an ER nurse. I triage patients much differently than people that are new. What I mean by that is, there are some patients that can sit in the waiting room versus sit in the back hallway. I just don't have time to do that and the three other things, right? And I'm not complaining, I'm just, not everybody's there yet. So developmentally, we got a lot of work to do.
At what point do you guys activate your surge incident command?
They do, so they do that, they open up, there is a surge unit. Along with that, we're reinstituting, the NEDOC score, which I think will be helpful. And I don't know if anybody knows what that is or isn't, but it's basically it's a overcrowding score that nationally they use in hospitals or have used. There's different versions, and what you basically do is you calculate or you implement certain things and resources based on your needs and the score. And so the intent is to hopefully
Like a fire.
light a fire.
But you guys are gonna hit 7 every day on that NEDOX. At 2 p.m. you're gonna be at a 7 every single day of the week. So I mean, but how does that help you if you're just doing a score that says that you're overcrowded when?
Well, the NEDOX, I don't know, you might be doing a different scale, but so NEDOX is 1 to 200.
Right. No, but the level, the overall numbers, yes, but the level becomes 7 is dangerously overcrowded. So 7 is the highest categorical, but it's over 200 is the score.
Not necessarily, but we'll see. It's to be determined, right? Once you get to the yellow, we only have 4 levels. And so once you get to the yellow, certain things change. We actually, yesterday, when we had 233 patients, we actually looked it up because Epic automatically calculates it, which is fascinating to me because used to be, we had to do it, manually in the old time days. And so, and it was, the score was 190. And so we announced it overhead and it was like a miracle resources, people came and it was helpful, like just simple stuff. They came and took patients upstairs versus us fighting to get them out. So I'm not saying it's the magic wand and not everything's gonna be rosy and perfect in the next month or two. But if we don't do something collaboratively, it's unlikely to improve and or we're always just gonna be in here going.
Well, I think that's where we are over the last
We're at.
year or plus.
Yeah.
And your assistant.
We have to move
Oh,
it.
I'm happy to help do whatever. I'm tough and ready.
So
what is
the actual threshold right now? For the surge, for the surge room, you're saying the surge, your incident command, whatever.
Their surge unit,
No, whatever, where your surgery over capacity. At what point do you guys say?
No more.
but it is very unlikely we will ever say we're on diversion.
No, I'm not saying
And I-
diversion, I'm saying at what
Well,
point.
that's the only option. Is to go on diversion.
No, I think his question is at
Like
what,
an internal.
what point are you opening up your surge center and surging?
Oh,
into that?
What is
that-
the triggers?
Oh,
When we
that,
open up extra services and start trying to decompress.
right. So the surge unit opens, I think, once we're holding 30. The surge unit is also dependent on staff from upstairs that they can get. So, to
So
be
you may
honest,
be at the capacity to open your surge.
and we need
And
it,
you just don't have staff,
and we
so
just
you're
don't,
not
and
open.
it's not that, it's just the hospital itself. So it may be that they need to open it or want to open it, and right, it's not like there's a magic button that we hit and it says, oh, surge is open, now move on. The other interesting problem with the surge unit is it's a specific patient set that can go there. So there's only a specific patient population, there's certain, obviously, you're not gonna put an ICU patient in the surge unit, those kinds of things.
I think what Dr. Clement's saying, and if I can try to clarify, a lot of facilities will also activate incident command. And what they'll do is they'll activate incident command due to overcapacity. And with that, then they start looking at resources of what they can do to
help decompress the ER, but also
The
get
answer to
patients
your-
out and get the resources where they need to go. Is that where you're trying to go?
Yeah, that's why, I mean, at what point do we say?
So it's not just
Like,
opening the
we get it
room.
on Epic Chat, a certain number hits at upstairs St. Joe's, you get a pre-surge message on Epic Chat.
And do nothing about it. Three things I wanna mention, don't compare our region to Syracuse.
Yeah.
They have ridiculous, they have ridiculous wait times.
Yeah, so we go
Overnight.
from Utica, Rome, and everything's transferred to the tertiary care center.
Syracuse also has a half hour, at 20
That's right.
minutes, we notify.
And that's what I'm getting at with this.
We notify the charge nurse at a half hour, they have to have it out.
Well, that's.
So the
All
same
the
way,
agencies got together.
I'm gonna tell my agencies, we're turning into dominoes. 30 minutes or less. And once that patient is on your property, you own it.
Not, that is not the case at Upstate.
Yes,
That
it
is,
is.
no, it's.
At 30, at
Dan,
20
you work there?
minutes,
When was the last time you were there?
2 weeks
Oh,
ago?
the patient?
Yes.
If
I work-
I don't, this isn't the right place for this discussion.
No, Dan, I think you're misinformed, because you don't work there and you don't work in the system. So
So
don't
I-
tell me you were wrong,
So I talk to Michelle a lot,
right?
so I'll take care of it.
Yeah, I mean, that's,
So thank
I would
you.
talk to her about the
I will.
pre-surge, the surge.
I will speak to her.
Yeah.
And I'll find out about their surge capacity and all that other stuff.
We just.
So thank
spent
you. I don't know the
$2.3
answer to your
million on
question.
the throughput center. It looks like freaking NASA mission control.
Yeah, I don't know the answer to your question, and we didn't build a $2 million.
Right, but I'm saying, and they're putting EMS in there too now.
Yeah, I don't know what, until I talk to Michelle, I won't know, but the answer to your question is, I would imagine that once the NEDOX hits 200, it's likely they will implement some sort of incident command, but I don't know the answer because I just started working.
Can I say something? Cause
Sure.
I used to work at Paxton St. Luke's when they had NEDOX in place.
Right, I implemented
And
it there, but
the response is exactly,
right.
deflation of the hospital, focusing on discharges.
Well, it sounds like he knows about
And
NEDOX, so,
so there, not only just the little things where you go down and kind of help the ED, but there is a higher level
right.
push to
It's
get
not
people
just,
out.
it's not just an ER response. It's-
So I'm fairly surprised that you haven't had that in place and.
No one was more
although
surprised
I think
than
if it is, if it is in place, I think it should help the way that.
To be determined, and
Right,
it's always
right.
modifiable as.
It's, and essentially, it's an incident command. It's the whole hospital focusing on clearing out the ED. That's really the premise,
July-
but that's.
July
what you're
1st,
doing,
it
yeah.
officially goes live.
And that's my whole point, and what I think this group wants as a whole. Is we want some answers of how you guys in the hospital center are better allocate your resources. So we don't have to diminish ours. And we can get our people back on the streets and get back to treat patients.
What about a PR campaign, working with the hospital and us as EMS to try to kind of goes along with Rick's thing that, like you've done it during flu season about, when you should call an ambulance, when you shouldn't call an ambulance. What I'm seeing too is, it's kind of disheartening because we only have one hospital in Utica, which it is what it is, but also as an employee of the hospital and being out in the community, when I'm picking up these patients in the community I work in, I don't want to go to win. The media has beat the win so bad.
Yeah.
And now it's affecting, so now I have patients in Madison that want to go to Oneida, they want to go to Rome, they want to go other places, they don't want to go to Wynn, even though we try to, direct them accordingly, they want to go to Syracuse.
Yeah,
They don't want to go to
I think-
Utica because the media has beat.
I
the
think
win
some of
so
it
bad.
is the media. Some of it is self-imposed because the patients have gone to the wing and waited hours. They don't want to be there anymore, even though they're a dialysis patient. You gotta go, either that or we're going to Syracuse, take me to Syracuse. I mean, that's a
But what
lot
can we,
of.
what
the
can we
thing.
do to all work together?
We don't see that with our patients. When they say they don't want to go to the win, it's people die there. They say, I heard a lot of bad things about the win. They've never been there. These patients that say they don't want to go to the win.
I mean,
That's the issue. We have to convince them, but then these patients that refuse now go to Rome, now have to be transferred. Some of them end up at the win if they can, but now we're taking them further away. And then we put Syracuse at capacity with these transfers.
But I think,
I think some of that, though-
And the way they open that. Part of my
You gotta
friend was
fix
a
it.
cluster, you know what?
but the media took it the wrong way.
I'm wondering if you could
We should take it
explain
the
one
wrong
thing
way.
to me
They should have closed the hospital.
that I don't understand about.
Hospitals are-
Yes,
or a cath lab.
It was put yesterday, or the day before, there was 100 in the waiting room. And there was 40 admit holds, am I right? That number roughly,
You're talking about yesterday?
yeah, I think it was.
At one point there, I said that, yeah, there was 100, we had
Okay.
109 active patients.
Okay, but you had 40 admit holds.
Correct.
Okay, can you explain to me, and this is
Very
an
unlikely.
honest question because I don't know the answer. How can you have admit holds?
Very
I'm
good
just
question.
curious.
That's,
Is it
every-
because,
every hospital in the
There's
country's
patients-
got them.
okay,
Yeah,
but-
that's not
Oh,
uncommon.
I can answer this question very simple.
and I'm not being wise, I
I'm not
don't
even-
know the
It's
answer.
money. Because whether they're upstairs in the hospital or in the ED, they're billing for an inpatient stay. You're from the hallway at Upstate, or you're in the hallway at St. Joe's or the Wynn. The hospital is charging the same amount of money as if you're in a room.
Yeah, fortunately.
So
we
they don't give a shit
But how can
because
you,
they're making money as long as they're sitting in the ER.
okay,
And we had the same problem at Upstate.
my question was, if you had 40 holds
Yeah,
for admit, does that mean that you had 40 patients that you knew were leaving, so those patients were
Some-
allocated to those
so it
beds?
depends on if
I
they
don't
had,
know.
it depends on if they had admitted orders. Right, so there, a person can go in and see a patient and say, I wanna admit him, but I'm gonna do this, and this, and this. So then they're gonna do all that stuff, and then, once all that's back, you're gonna say, Dr. So-and-so, he needs to be admitted. So then Dr. So-and-so, now we do transition orders, or Dr. So-and-so will enter the orders, and then you have orders, now you're looking for a bed. Then there's
But if
patients,
you know you don't have a bed, how can that be a hold?
then they got, well, I don't know where they're gonna go.
They're admitted, but there's no bed
They're
available.
admitted, but they're in the ER,
Rome
and they're
doesn't.
charging the same amount of.
That's fine, I just don't understand.
Yeah, no,
Yeah.
if
So we do it.
they're admitted orders is what they're called. It's a nasty word in the ER, but they're admitted orders and it's an awful problem.
Do it.
Okay, so basically, we have to make sure that EMS is not the stretcher for those EMS boarders.
That's
Well,
our concern.
What we're doing now is we're swapping out admitted, now I'm having them bring hospital beds down to put the admitted patients on hospital beds to get them off of our ER stretchers because we, like yesterday, we needed ER stretchers so bad.
So our patients would go on the ER
The
stretcher,
ER stretchers
and then
to get their
admitted
guys
patients
out.
would go out in the hall.
Correct.
That way, we're not
Well,
helped with staying with the
The
patient.
other issue, one consideration also is that I've heard anecdotally that allegedly we're not allowed to have hallway patients. Which is really not a thing in an ER
They can't
anywhere.
be, because you've got ambulance hallway patients, there's no difference.
Right. Look, I
So that doesn't make any
Just
sense.
say,
really likely you're gonna tell me all the stuff and I'm gonna agree.
I've worked with Steve in the past. He's always been up front. He gets it done. He knows what he's talking about. Let's give him a little time. We invited the hospital folks here so we could have a discussion. We've had the discussion. And let's let him do whatever he can do and look at this.
But I'll
monthly.
take help though.
And he'll take
And I can
help
set up a group and
from the guys on the street. Thank you for the water and whatever. snack
Oh,
you
yeah,
can
that
do.
was,
We
you guys,
appreciate
thank you
that.
yesterday.
we're having a barbecue
Absolutely.
tomorrow.
Not sure we're gonna have crews available to do that, but
Well, it'll be
it's
there.
great. Smell it.
Thank you.
We'll come
All right.
and grab a hell of a pancake. I'm gonna,
Can I say something?
I'm not targeting.
Oh, that's more to help.
Well, I promise. Well, I just say that, transparently, I think the transition from SOMAC to Madison County EMS for community memorial has been quite challenging. Would you agree? And regularly, we meet on a regular basis, whether it's a contentious conversation or a good conversation but we meet monthly with our medical director from the emergency department, our manager from the emergency department, and our administrators. Any of our administrators that are available. I'm in all of them.
And Arma.
And yes, and her team and Dr. Black, he comes too. So, I mean, I think that for that, because there's specific issues that we have to work through, it's been very helpful. So I would make a recommendation to pull together the right people, as you said, a team of people, because I don't think the hospitals can do it alone, nor can EMS. So I just would like to,
So Heather, are you only meeting with that one agency in Madison County?
yes.
Why
And this-
are the rest of us not included in that meeting?
Well, there has been discussion about including all other EMS around the county. But we haven't come to that.
And it's.
I mean,
Our primary contact.
That's,
And this is really, a lot of the things have to do with the CON or, you know, or transfers and.
and that's a discussion,
And it-
not to say it's not important, but that's a discussion that agencies can have with Madison County. Probably more outside. I think we've had some good discussion. Some of it seems to have gotten a little bit astray and, to some degree, a little argumentative. But what I will say is, it seems to me that they're working on trying to solve it. They're coming up with new solutions. The one they came up with yesterday. They meaning the ER, I guess.
Yeah.
The Steve. But I don't want to minimize it. I don't want to.
ER though.
Right, I don't want to minimize that it's only the ER, it is a bigger problem. It's not gonna get solved overnight. We've had a lot of productive conversations in this meeting, and we'll need to have more, I'm sure. So again, it's not gonna get solved tonight, so unless there's anything else pressing for the hospitals, I'd like to move on. Gail?
So, like, as you said, conversation has been really great. But I'm looking here, we have committees for everything except for a hospital committee. Maybe we can set up a hospital committee that they can come in at 4 o'clock and have this conversation. Those representatives come back to this committee so that we're not hashing it out with 30 other people. So, the three main hospitals and.
I agree, though, that I think that each individual hospital ought to come up with a crew. I mean, like Hamilton, it makes sense you're doing what you've done. I mean, there's no sense of me coming down to
Right.
Utica when, it's not saying I don't go to Utica, but, I mean, your local problem is your local problem, I mean, yes, tonight and should, I should be in a meeting with Anida, but, Kunkel coming down to Anida for me is kind of ludicrous.
Yeah. And I mean,
each hospital.
from everything I'm hearing, it seems like we've got the right person in the spot that's hearing our concerns and seems to be doing something about it. And I thank you, Steve, for everything that you've done so far and hope that good things continue. So one thing that I will address on Nick's statement there about the patients that don't want to go to WIN. Speaking personally, I think it's our responsibility in EMS to do customer service, whether it's customer service for our own agencies or even customer service for our hospitals. What's your concern about going to the WIN? Well, you've heard some things in the media, but that's not really what I've experienced or what my family or what other patients have experienced there. How about we give it a chance? And I've done that myself. And I think that it's a good idea for us to at least have those conversations, no different than, well, I don't want to go to the hospital. Well, why don't you? Well, because I'm afraid I might get admitted and I might lose my house and I might, end up in a nursing home and, so it's kind of along that same line. So I think it's important for us to not just, oh yeah, no, they're horrible there. They don't know what they're doing or whatever the situation is.
But I've done that, talk them into going to WIN, and then you sit there an hour and a half, 2 hours, then you look like an idiot.
Well,
Well, yeah, I know, so don't blow it off here.
I'm not trying to blow it off, Bill.
Well, you are.
No, I'm not.
Yeah, you are, you say talk them into it, and then you look like an
I
idiot.
didn't say talk them into it. I said, ask them why.
Yeah, you do, and then you talk them into going there, and then you sit for an hour and a half, 2 hours, and you look like an idiot to them.
So as somebody very,
You're not talking here in Utica where you don't know the people, when in Bridgewater, you know everybody there.
and if they've got legitimate concerns, you don't talk them into it. You say, okay, then let's see where else you want to go. I'm not saying you kidnap your patients and force everybody to go to the WIN.
I'm not saying you force them to go,
Well,
but
you're turning my words around.
No,
so
I'm not.
You did. You sat there and said, I said to talk them into it, and I never said it. But we're getting off topic, and I apologize.
Does the Wynn Hospital, have an ombudsman program? Live and active perhaps? Or could there be implementation of an ombudsman program within the ER to advocate for patients that are having these complaints? Because that, what Bill is saying and everybody else is saying is a very valid and common complaint. I experienced it yesterday, and much like what Bill said, it was the same scenario. I had a cardiac patient that was insistent on going to Rome. He was a CNY cardiology patient. Long story short, he sat on a hospital bed in the Columbia Street hallway for 7 hours. And, you know, this guy is spit nails at me. And there's nothing I can do about it, but in the best interest of his continuity of care, he went to a Utica hospital where a Utica cardiologist is following him versus going to Rome where he requested. Now I'm gonna get verbally assaulted via Pulsera from the staff out there, get into a fight out there with them, have to talk to Jared about it. And you got a St. Joe's cardiology affiliate that knows nothing about this patient. This is an ongoing thing that we deal with on a daily basis, and I think that's what Bill's frustration is.
Ultimately, the patient, we're not in charge. Patients are in charge.
But we should be taking patients to appropriate facilities too, not just dumping them
I
at
agree.
a community hospital and then causing more work on transfers to a community hospital.
I mean, that's in the EMS system why. I mean, we have guys in Syracuse who will dump patients at community because they don't want to drive the extra 20 minutes to St. Joe's where the guy's got established care.
Dave,
So I guess my take on the entire event is there's a lot of discussion back and forth, but the size of this committee is not conducive to getting anything done. Is there a seated committee now whose composition represents the different classes, i.e. like the executive committee represents municipal fire, commercial EMS, volunteer-based EMS? We could sit down in a smaller group and, as we do with all the other committees, bring seconded motions back for how to fix it in a work group environment that's less argumentative, more productive, because this is not the forum to do what we're doing right now. Does that make sense? Because if we go with a committee that exists, that takes away the whole spin up of creating a committee that already exists. Assign it to executive who represents across the board all the different types of EMS. That would be my recommendation.
looking at the committees that are listed, the two that immediately come to mind, one is ambulance and the other was safety.
Either one. Based on their composition, you can choose which one is most reflective of all the different components of EMS, and assign it to that and make it a work group there. It would make a lot more sense.
Why can't we have a facility management committee?
We can have whatever committees get approved in the bylaws. So all we need is somebody to make a motion and put a sign up, put a bylaws together.
Committee or standing.
It could just be a tag.
You're right, it can just be a group under a standing committee.
Okay.
What that?
Yeah.
I don't think you need to be a bylaw advisory group. It's not standing committee.
They can be a tag group.
Right.
Just, and it can.
Let me make a motion.
Does somebody have a motion to make? That we form a committee small enough to handle this, representative?
I'll make that
enough?
motion what you're saying. I like that.
I'll second that motion.
What's the motion?
The motion is to create a
Tag.
tag committee, tag a
Technical
committee on
advisory
something.
group.
So we have a
But
motion,
it
we have a
needs
second.
small.
Any
You
discussion?
had a second too.
Who wants to take the reins? All I need is someone to raise their hand and this discussion is finished.
Well, next try.
Well, no, because the next time we talk about it, hopefully there'll be much more.
There you go.
I'll take the reins on.
There you go. Okay.
Nick.
Anybody that wants input on this issue, we now talk with Nick. Nick will form the committee and it's gotta be representative of,
There will be a technical advisory group.
there you go.
We'll put a technical advisory group under, yes, safety committee. And
Can you stipulate in
Nick,
the
that'll be your responsibility to report to Josh on
can you
what you
stipulate in the
can
motion?
get, and, I'm sorry,
I'm sorry to interrupt. Can you stipulate in the motion that it would have a representative of each major grouping of EMS?
Right, municipal, private, volunteer.
Yeah. All right, so-
Doesn't ambulance committee already hit that?
Cause they should be a tag, I think, under.
Yeah, we don't,
Does it not?
yeah, we don't handle every other state action that happens, okay, so.
No, I'm
Yeah.
just saying, like, the ambulance committee, we have pretty much someone of everything.
Can we have a
Architect will
designate of the
decide who's
CEO
gonna
of
be,
the hospitals? So tag under our ambulance committee. Then. Can we have a designee from the CEO of the hospital? So they can report back to the CEO, the money person? No, I'm just saying, because when Win opened,
I don't understand the question. What's your question?
I want somebody from the upper echelon administrative of the hospital
Besides me
involved. Yeah, cause I want a decision maker,
I'll let them know.
because when they opened it, it was disgusting.
Okay.
You know, if Darlene was in the meeting for 2 minutes and had to leave her.
I think you have another agenda, and I'll let them know that you would like somebody other than me.
No, it's not anything about you,
All right.
it's just, you know,
That's not the REMSCO state.
What,
That's fine.
the motion on the floor is to create a technical advisory group with representatives from various agency types, municipal, commercial, volunteer, et cetera. And we will reach out and attempt to have hospital representation on that, preferably at a level that can help us answer questions and affect changes. So we have a seconded motion. Is there all in favor?
Aye.
Any opposed?
No. Who do you want to tag report?
Okay. It's gonna be under the safety for right now. So Nick, get representation from each of those agencies, work with Josh, for help developing that if you need to. And then report back to him on a regular basis of your findings, and we'll keep that updated through part of the safety report. Okay. All right, anything else under new business?
I just wanted to.
New business. Okay. Next meeting is July 22nd, 7 PM here.
Make a motion for adjournment.
Second favor.
Aye.
Thank you.
Hey, Jared. Jared,